history of presenting illness. The child was all right till yesterday. Then he developed giddiness while he was playing, which was sudden in onset, and had a feeling of revolving of surrounding objects, and was not able to stand or sit. And he was actually having this kind of episodes every 2 minutes. And after that, which was associated with ringing sounds in both ears, and it was followed by a headache of gradual in onset, non-progressive, no aggravating on relieving factors, frontal in location. And after the admission, the child had two episodes of paroxysmal events associated with tightening of left upper and lower limbs, deviation of eyes, mouth, and head towards left side. But it was not associated with frothing at the angle of mouth or any bowel or bladder incontinence, which was lasted for 15 seconds. And there was no PID. Negative history, no history of trauma, no history of fever, vomiting, or any blurring of vision, no history of altered sensorium, no history of focal neurological deficit, no history of any ear discharge, no history of no history of difficulty in speech, no history of bowel or bladder disturbances, no history of recent travel or vaccination, no history of any involuntary movements. Past history, there is no significant past history or any prior admissions. Antenatal history registered, regular ANC visits done, ANC visits are done. Mother is a known case of hypertension on treatment, no history of any other ANC complications. Birth history, preterm, and baby cried immediately after birth. Birth weight was 1.5 kilo, required an ICU stay for the same for 15 days. No ventilation required. And developmentally, the child is appropriate for age and goes to third standard with average scholastic performance. And the child is partially immunized till 1.5 year of age. And dietary history, dietary history has a total calorie deficit of 280 with a total protein deficit of 10.5. And socioeconomic history is normal and on examination. No, sir, no loss of consciousness. Focal seizures, no loss of consciousness.
So just summarize that a 10-year-old came with 1 day history of giddiness and headache. And the giddiness was in the form of
Giddiness was actually sudden and in the form of he was feeling like all the objects around him are revolving and associated with ringing of ringing sound in bilateral ears. And after that, headache, which was non-progressive, dull aching, frontal in location.
yeah. So this giddiness and this ringing, you said something about every 2 minutes. So was it getting better and coming or was it constant?
Sir, it was actually getting better on the supine position. When the child is supine and doing nothing, it was actually fine. And when the child starts to get up and move, it gets aggravated.
Okay, and it lasted for a few hours.
It just it lasts for 1 to 2 minutes, and these episodes are very frequent since 1 to 2 days.
And then the second that started.
Immediately after giddiness, headache has started, but convulsion happened yesterday after admission.
Correct. So the whole thing has happened over 24 to 48 hours. And the headache continued.
Headache continued.
So what are your initial thoughts on giddiness? Where could be the different anatomy and how do you figure it out? Raise your hands and ask for the mic.
So inner ear could be one of the localization for giddiness, one of the site. He can have labyrinthitis. So in such case, he won't prefer to walk, like whether he is walking or sitting. everything around him would seem like moving.
Okay. What else?
Uh, Sir, it can be a central cause also, or yeah, related to inner ear. But child did not have any vomiting, or so we need to differentiate if it is a ear or a central cause. And he did not have nystagmus, but there was tinnitus. More likely, inner ear could be there.
Okay. Uh, he said the ringing is bilateral. So what does that tell you?
Can be central also, because if one ear is affected, then same ear tinnitus will be there. And since it is followed by convulsion, more likely central cause.
I think first when somebody comes saying giddiness, you need to be very sure what it means really. For example, is it an ataxia that he's saying, I'm feeling giddy? What is giddiness? So you need to ask whether, do you think everything around you is reeling around or you yourself are reeling around? That is giddiness. So giddiness has to be defined correctly because giddiness, ataxia, seizure, all may look similar. Okay. Especially with non-motor seizure, it will look something funny. Okay. And therefore, first to be sure what it means. Now, suppose we mean really a giddiness. Okay. The next is, does the posture make giddy? Okay. I have a postural hypertension. I suddenly change my posture. I start feeling giddy. Okay. I move my neck and head. I may start feeling giddy. So, how are the episodes activated? If you say it's probably the ear, okay, and not the cerebellum or not any other tracks going through cerebellum, then moment you say that, you start wondering why is this ear problem, atrial problem? So is the hearing all right? Have any problem? Okay, all that are questions to be asked only. Then only you are sure what you are dealing with. Then has there been a fever? One of the commonest cause is an acute onset viral infection. Where you suddenly start feeling, okay, as we call vertigo. So we need to be sure about that. But if there was nothing, then was it an acute onset vascular? I recall somebody having a posterior uh, blood vessel problem with cerebellum involved would start fearing that, oh, I'm falling down. So many thoughts will come out of that. And I think I imagine this is vertigo. I imagine therefore this is some inner ear. And then we go further and discussing.
So does bilateral make it a little different from inner ear in the sense that inner ear would have to be unilateral or not necessarily?
Not necessarily. Okay. For example, if it's a viral infection, which is probably the commonest cause of a transient problem, which settles down over a day. Okay. But there are different reasons. For example, a vertigo could be episodic. Okay. And the causes are not clear, whether it's some degenerative local. So I feel even if it's unilateral or bilateral, it could be either way. Right?
Now, sir mentioned, could it be a vascular problem? So any further thoughts from that?
That could have been unilateral.
Any further thoughts or thinking about that? So I'm asking you, can you think of some other situation where you get similar complaints and then you get headache also? One is posterior circulation stroke. What else? What about migraine?
It's
And
stroke equivalent.
It's a stroke equivalent, right? So migraine is also a possibility. So that is, so would you, so in that case, what history, additional history would you ask? Ask for them.
Some more details about the headache, if any aura was there or not. Although migraine without aura is much more common than migraine with aura.
Okay. What else? So to diagnose a child with migraine, what are the important things in the history which are, which help you?
So unilateral throbbing headache.
Okay. So is it always unilateral? No. So unilateral doesn't, or bilateral doesn't rule it out. What else?
So getting relieved with rest, like on certain stressors dissipating the headache.
Okay. So one is relief with rest. Then
So preceded by so family. So any family history of migraine if present, preceded by or associated with nausea, vomiting, or any floaters, black spot in front of the in the visual
so
field.
family history of migraine is very important. Then past history is also very important. I mean, of course, you can hit on the first attack of migraine, but usually there will always be a past history of recurrent headaches, right? Now, this headache was frontal, dull aching, and constant. Yeah. So, most important is that when he slept that night and next morning, was the headache still there?
It was actually in a decreasing trend since past 2 days. Initially, it was a more severe intensity. It's like that he was saying, and as the day progresses, it decreases in intensity.
Now, what about the seizure? What do you make out of the seizure? What is your interpretation of the seizure? You said left-sided upper and lower limb for 15 seconds with some important things you said, which normally are not there, which were there this time. So what are,
Deviation of head towards left side, and
okay,
eyes, and uh, uprolling of eye.
rolling of eyeballs was there,
It was this.
right? And what was not there?
There was no frothing, and there was no bowel and bladder incontinence, and
So what is the importance of frothing? What is the importance of bowel and bladder? Means if it's there or if it's not there, does it make a difference?
More of like it can point out towards more of generalized seizure, and like the lobe involvement also. It at times it can tell us
What? Frothing.
no bowel, bladder.
Yeah. So the question here is the consciousness affected in this child or not?
not affected.
So consciousness was not affected.
Not
So this was a focal seizure with preserved
preserved
consciousness.
consciousness with no PID.
Okay. So what do you make out of that? Means what does that tell you?
It may not be a seizure person.
It rule out metabolic cause.
Can have some focal irritative lesion in the brain which is triggering that.
The pathology has to be focal, right? So that is something which is important. So what I'm trying to drive at is that the seizure seems to be pointing to a focal pathology, whereas your giddiness and bilateral ringing in the ears seems to be pointing to a generalized problem rather than a local problem. So we are at a little bit of a confusion there. Tushar, it's a 10-year-old boy, girl, boy with 1 day history of giddiness, multiple episodes every 2 minutes types, with ringing in both the ears, followed by headache, and was admitted for this, and here threw up focal seizure.
Getting episodes of giddiness every 2 minutes means to me that it's a continuous process only. Okay. When I feel giddy, I support that few seconds I may be all right, but again when I change my position, I again feel giddy. So every 2 minutes, I don't think it's a recurrent giddiness. It's a continuous giddiness. My next question was, how do you know giddiness is coming from only one side or both sides? Unless you have some other symptoms in the ear, only on one side and not the other, even then you may not be sure. So I won't bother about unilateral inner ear problem or a bilateral. I would say no, it is an ear problem. So again, therefore, that may not be focal necessarily or not. It may not be general. So one is focal, another could as well be focal, and therefore we will take it as a two separate episodes of focal sudden onset. So focal vascular episodes at different times at different areas.
I've joined in late, but from whatever I am gathering here, you have ringing and imbalance. Both of them point towards vestibular and the ear area, which typically don't give rise to seizures. So again, that there is some amount of discrepancy about that, unless you say that there is a generalized edema and that is responsible for seizure, then again it will not give you a focal seizure, and there would be altered sensorium or some pointing towards that particular thing. Unless you call all these as a vascular phenomena in terms of migraine or migraine-like illness, and then try to corroborate with something else.
Okay, so we'll go ahead with the examination findings.
Before that, do we think clinical examination will guide us somewhere? Just let's make a guesswork. Okay, we are saying migraine equivalent, etc. What is the clinical examination going to show us? So would you expect something in clinical examination? And what would you be looking for specifically? If it is not migraine, but migraine equivalent, then what is this equivalent mean? So can we make some guesswork?
We can differentiate between cerebellar and vestibular causes.
Examination, you are saying.
On examination, if there is a signs of any cranial nerve involvement, uh, eighth nerve involvement, or cerebellar signs.
Okay, so one is you will be looking for eighth nerve involvement in any way. That is one, agreed. Cerebellar signs you will be looking for. But from this history, we are not very strong on cerebellar. Mostly we are expecting cerebellar to be normal from this history, right? So that is one. What else? We talked of different vascular phenomena. So from that angle, what are you looking at on examination? Focal neurodeficit, if any. Okay. And that neurodeficit is over a time frame likely to be transient, as in recovering fast if it is vascular. Yeah. Let's see.
Examination, vitals, afebrile, pulse rate was 67 per minute, respiratory rate 22 beats cycles per minute, peripheral pulses well felt and extremities were warm. BP was 100 to 58, which was between 58 to 98 centile. And otherwise is normal. And head to toe examination is normal, head normal, no dysmorphic faces, no neurocutaneous markers. And systemic examination, higher mental functions, alert, conscious, oriented to time-based person, memory intact, both immediate, recent, and remote, and speech and intelligence also normal. Uh, Cranial nerve examination. Uh, Almost all cranial nerve examination normal. In vestibulocochlear nerve, in Weber's test, that is lateralized to left ear, and Rennes was positive in both sides, which is normal, and rest of the cranial nerves was normal. And cerebral signs, finger nose test, pass pointing was present, and dysdiadochokinesia was absent. Rebound phenomenon was absent. No tremors, nystagmus, or any dysarthria. Titubation was not there. Gait was also no, gait couldn't be checked initially, but as the time progressed, it was normal. And tandem walking, he was actually swaying forwards, which was inconclusive. And heel knee test was normal. Upon Romberg test, he was swaying on both sides, and no signs of any meningeal irritation. Motor system, bulk was normal and equal on both sides. Tone was also normal and equal. Power 5/5 in both sides in all joints. And reflexes were also 2 plus. Plantars was flexor and no clonus. Sensory system was also intact on both sides. And rest of the systems were also normal.
He'll call the child. Child is here, no? Sir.
Giddiness means we need to live. The whole world is moving or he feels life falling. Here it was real giddiness. एका बाजूला बघितल्यावर जास्त होत होतं, मान फिरवल्यावर जास्त होत होतं, का कसंही केलं तरी सारखंच असा होता. अशी मान केली असं केलं की जास्त व्हायचं का असंच सारखंच होतं का आता लक्षात नाही. सारखंच होतं. या बाजूला केली तरी या बाजूला केली तरी सारखंच होतं. जास्त डोकं दुखत होतं का जास्त चक्करेचा त्रास. डोकं विशेष दुखत नव्हतं. पोटात दुखत होतं.
Do you have a tuning fork? You were talking of Rennies and Webers, so we wanted to know how you do it, and then what is the meaning. Does anyone have? Okay, no. So you said Weber's was lateralized to the left ear. So what does that mean?
It may be a conducting on the left side, conducting deafness on the left side, or the sensorineural deafness on the opposite side.
Okay. And then you said there is a Romberg sign positive.
Yes, sir. Romberg sign was positive.
Show us.
Initially, it was present on presentation, but over time he improved over 2 days.
So my question is, did you expect Romberg sign? Suppose it was present, where would the problem be? Posterior column. So we were discussing a inner ear problem, then we said possibly a CNS problem, and now a posterior column has also been brought in. So these kind of different anatomies, do they fit into any picture? They don't. So I would have expected Rombergs not to be present, and maybe I made a mistake in checking or something like that. Also, one point is that if originally only the child is feeling, see, Rombergs is you have to start from normalcy, and then when he closes his eyes, he feels unsteady. But if he is already unsteady, then you can't check Rombergs, no? And then you can't come to the conclusion that look, after closing the eyes also he was unsteady. So maybe that mistake we made, right?
Can you please show that he was unsteady even in standing, but closing the eyes aggravated his symptoms? Whether that would also mean a positive rhombus.
Okay. So there's no other positive findings, right? Yeah. Right.
काय होतं म्हणजे डोकं दुखतं का त्या मिसेसचं डोकं दुखतं का उन्हात चाललं तर डोकं दुखतं का आईला बीपीचा त्रास झाला हा पोटात असतात पण त्याच्यानंतर या हा जन्म झाल्यावर माईचं बीपी नॉर्मल आलं का अजून बीपी आहेच त्यात एवढ्या पुरतच
ठीक आहे, थँक्यू.
हा इतक्या दिवसात सुधारतोय का हा त्याला एक बाजूला हसत आता 4-5 दिवस काय झाले असतील हा सुधारला का किती 70-80% सुधारला रुपयात 14 ने सुधारला
Impression: 10-year-old male child. First by birth overcame with complaints of giddiness, tinnitus, and 2 episodes of paroxysmal event with a history of NSUST in a developmentally normal and partially immunized child. Is a case of focal seizure secondary to any uh, space of pain lesion or in benign paroxysmal positional vertigo.
So in vertigo, the seizure, then you are discounting the seizure.
Though it may be a completely different entities.
Okay.
vertigo and headache and all the three we would like to correlate, isn't that so?
Yes.
Now, normally in a vertigo, there should not be much headache and severe headache.
His first complaint was vertigo only, sir. Headache is just collateral.
Okay.
And in investigations, CBC HB of 11.6, HCT of 34.7 with total counts of 5,400. Platelet was 2.3 lakhs. And LFTs was normal. RFTV was also normal. CT brain plan has been done, which showed mind dilation of both lateral ventricles, which was suggestive of normal pressure hydrocephalus. MRI has been done today, sir, and EEG is being planned for that.
What treatment have you given him?
So we are just given a conservative management. No specific treatment has been done for convulsions. We started anti-epileptic drugs. That's it.
So at some point in the discussion, you mentioned that it may not have been seizure.
Yeah.
So why did you mention that? Because honestly, one of the diagnoses that I'm thinking of is a conversion disorder because nothing seems to be fitting in. So that's why I'm asking.
It, I just thought it may not be a moment. It may not be a seizure. It may be a brief moment disorder. It may be.
What did the observer say? How did he describe?
Uh, he actually said that there was a tightening of upper limb and lower limb associated with deviation of eyes and neck and head towards the left side for 15 seconds. That's it.
There was no
With no
chronic
tears,
phase. There was only tonic phase
only tonic
with
phase,
deviation of eyes to affect.
deviation of eyes.
Sir, my point is to correct me if I'm wrong, but deviation of eyes and deviation of neck to one side without affection of sensorium and without postictal drowsiness, I thought they are not going hand in hand.
Unless one considers this like an extrapyramidal reaction to whatever we have taken, and that would go with migraine, vertigo, or drug related or food related.
Yeah. You're getting what I'm saying? Means seizure, if you're getting deviation of eyes and uh, uprolling of eyes and deviation of neck to one side, and you call it a non-generalized seizure, that seemed a little discrepant, I thought. That made me suspect a conversion disorder because nothing seemed to be fitting in.
Sir, actually, child was admitted day before yesterday. So they came from Satara. Their child had giddiness and headache. So when he came, he was swaying only. And next day morning, he had a convulsion, which was actually when he was coming from that X-ray. While coming from that X-ray, he had, which was only seen by the parents and mama. So what they described is focal convulsion only. Post convulsion, child improved. That swaying, we started on Levera, and post convulsion swaying was significantly increased after Levera. We have not witnessed the convulsion, but decreased. Yeah. We were thinking in terms of could it be an aura prior to convulsion, which has decreased.
Meaning the giddiness
Giddiness.
as an aura. No, but again, too long is one issue, and the second issue is that it will not lead to a focal seizure like that. Yeah, aura is always a no, but this kind of aura with a focal seizure is very unlikely. Means, see, where is the aura coming from, if at all? If it is coming from the temporal lobe, then you would have what we used to call a complex temporal lobe epilepsy with behavior changes, this, that, not a focal motor movement. Yeah. So I think, yeah. Anyway, we are at a blank as to what.
Three things are clear. He said it. Foci also. Whatever it is. So probably it's a vascular phenomenon involving, there was no cerebellar thing whatsoever. There was headache. Whether the headache was also, it's also a vascular phenomenon. Whether all they are maybe little difficult, was transient, and it may recur. We may have to keep in mind. The bilateral hydrocephalus probably, it's not that uncommon variety of headache. I mean, hydrocephalus non-progressive. So significant hydrocephalus.
Online viewers, anybody wants to ask any question or give a comment?
Migraine can also cause a seizure. So whether we can consider migraine, although we have to rule out an SOL or any vascular issue.
Past history.
Yes, that is not there, and no maternal history. But Rajesh, your voice is breaking.
Your voice is not coming, Anjali.
Even yours, I cannot hear your voice also clearly. Even Dr. Khare's voice, I could not hear. I don't know if others also are facing this.
Yeah. No, now it is
And
clear.
now we
Now it
can
is
hear
clear.
you.
Now
Now
Can
it
it's
is
you?
clear.
clear.
Yeah.
Yes, ma'am.
Even
The
now I
same
can
issue.
hear you, Rajesh.
Yes, ma'am. The same issue was previously there.
Yeah.
Any other comments or inputs? Then otherwise we go to the next case.
Whether,
Yeah, Amdekar sir.
whether normal pressure
Okay.
hydrocephalus can be incidental finding? Whether normal pressure
Yeah, I mean, it doesn't, the normal pressure hydrocephalus doesn't fit in. No, it doesn't fit in with
can be an
anything.
incidental finding.
So first of all, I would even question or confirm that, because mild dilatation of ventricles is something which could well not be there. So we need to reread that or whatever. Yeah.
I thought we could try to induce the giddiness and see whether what is the reaction to it. For example, you could run the cold air into the ear canal and see whether that stimulates his giddiness. And at least we will know the anatomy is there. Okay. Then we could say, well, etiology looks to be vascular because of a sudden onset. Then the question is, what was this so-called focal seizure? Now, the story is both upper and lower limb. So I don't call it a focality as well. Okay. And therefore, it's likely that it may not be organic as much as it may not be vascular either. And therefore, possibly, I would induce a giddiness if possible. It is recently that he is recovering. He could still show giddiness when you run a cold water into the external ear. That's at least worth to pinpoint that. Then possibly we will have to and see which vascular disorders may recover but may again recur. And I'm sure at this stage he has had nothing in the past, but otherwise some inborn neurometabolism, mitochondrial disorders also could have a vasculopathy. Whether he's going to run into another episode, we don't know. So at this point of time, at least anatomy can be definitely seen if you can get him to show the reaction similarly. And then I think wait and watch to see what next can occur. But we would leave it as not certain what it was. If it was a migraine, he would come with headache, he would come with something else again. If it was some other cause of vasculopathy, then he would show out. And I feel that's the way to go.
In addition to giddiness, was there ringing also?
Yes, sir.
So
It was there.
ringing, the child may not know that he should, so to say, manifest as a functional disorder. I can mimic a giddiness, but I will not know that the giddiness should be associated with ringing also, unless I am a medical person. So ringing with presence of giddiness means it organic.
Sudden onset and now recovering quickly. Then that is not functional. The question is whether what you talk about left-sided is not organic. I have no idea at all. But the giddiness must be genuine. And therefore it's an organic thing. That's why I thought we could induce it again and see what it is. After all, if I have a drug allergy and I've got out of it, do I not challenge again and confirm that it was a drug? So confirm it if possible.
Fine. We move to the second case. Yeah, thank you.
Did you consult an ENT surgeon?
Yes, sir. ENT call has been sent.
What was their opinion?
They've actually yet to evaluate the child. The child has yet to be evaluated.
Yeah, yet to evaluate.
So by the time they start, if you get a history which is suggestive of vertigo as pediatricians, we can ask a few things. First is to find out in which direction was he feeling more giddy, because not all three cervical canals will be affected at the same time. Especially those who are having BPPV and recurrent ones, they will classically tell you that when I look up, that's the time when I have maximum vertigo. But when I look on the sides, I don't have so much. Second common thing you can ask is if you move your head, do you get giddiness more? Does it increase or not? To be a bit careful, sometimes with sinusitis and headache, also that this kind of symptom can come up. The other thing that you can ask is ask the relatives, did you see the eyes dancing? Because if you go to the ENT, especially the vertigo specialist, they will do the maneuver and they will try to find out in which direction the nystagmus is maximum. And that will tell me them, depending on the fast and the slow component, which semicircular canal is affected. And then they would do the Epley's maneuver to put all those particles back inside the ampulla and to revert the episode of what. So these are some.
Four and a half month old FCH, third birth by order, one of non-consensuous marriages, resident and hailing from Parbhani, Muslim by religion, Khan by community, brought by mother with complaint of yellowish discoloration of the eyes since birth, and complaint of passing high colored urine since birth, and complaint of irritability since 15 days in form of refusal to feed. Discoloration of eyes since birth, gradually progressive to involving all over the body, including palm and sole, over the next 2 months, and which is associated with passing of high colored urine with severe irritability. Then also there is a history of irritability since last 15 days in form of refusal to feed and increasing cry while awake. Then on further inquiry, child has history of abdominal distension noticed since last 2 months, insidious in onset, gradually progressive, not associated with edema of other side, not associated with breathing difficulties. Then for the above complaint, child was admitted in local hospital. Some blood and radiological investigations were done and referred to our center for further evaluation. And then there is no history of bleeding manifestation, patagy, purpura, melena, no history of seizure, no history of delayed development, no history of swelling over body like pedal edema, periorbital puffiness, no history of difficulty in breathing, no history of significant NICU stay, no history of neonatal sepsis, no history of poor weight gain, persistent vomiting, lethargy, no family history of similar complaint in other sibling. Then past history, one hospital admission at third month of age in view of acute febrile illness. Some IV medications were given, papers not available. Then ANT history, registered, supplements were taken, TT injection taken, 4 ANC scans were done, told to be normal. There is a history of fever with abdominal pain in third month of ANC, required hospitalization and was told to be having typhoid. History of intermittent episode of vomiting throughout the pregnancy, not required hospitalization. History of itching of skin, palm, sole of the mother throughout gestational period, and also there is a history of easy fatigability, paleness of the skin, fever with burning micturition in third trimester, and there is a history of PRC transfusion in mother in third trimester. Birth history, full term, LSCS in view of previous LSCS. Birth weight was 3 kg. Baby cried immediately after birth. No history of NICU stay and discharged on day of life 7. Then dietary history, formula feed for the initial 3 days and then on exclusive breastfeed. Developmental history, gross motor, neck holding present at third month of age, currently tries to point to prone positioning. And fine motor, searching for object at 4 month of age, now transfer object from one hand to other. Then on social smile present at 1 month of age, mother regard at 3 month of age, language going present, impression appropriate for age. Immunization history completely unimmunized. And family history, father is 26-year-old laborer, mother is 23 years old housewife. And there is a history of one sibling death. Anthropometry, weight is 5.8 kg, which is between minus. Sir, due to the FTT, child was failure to thrive. And
And at what age?
uh, sir,
We'll come to other details.
no, sir, mother didn't give history of jaundice.
Okay, come. So, what do you all think? What is your impression of the history? 4.5-month-old with jaundice since birth, right? So, what are your first thoughts? What kind of jaundice is this? Conjugated, unconjugated?
Conjugated, sir.
Why do you say that?
So there is high color urine staining the diaper, the history of pale colored stool. So these two corroborates.
Fine. Now take it forward. So,
Sir, she also gave history of abdominal distension in
which is since last 2 months.
which is since last 2 months. So, sir, we have to differentiate now whether it is extrahepatic or hepatocellular causing the cholestasis. So, sir, if it is a sick child with not so severe jaundice and other stigmata like pedal edema, ascites, then this is hepatocellular causing cholestasis. And if it is extrahepatic, less sick but disproportionately severe jaundice.
So, what do you think in this child?
So, in this case, so I will take the abdominal distension. So I have to ask for further details whether it is uniform abdominal distension to distinguish it whether it is organomegaly or ascites as such. Or if ascites is present, then taking into account a stigmata of like liver involvement and hepatocellular causing cholestasis.
No, so I get your point, but the point is whether it is organomegaly or whether it is ascites. Do you expect either of them in biliary, extrahepatic biliary causes?
No, sir. Not ascites.
Do you expect organomegaly?
No, sir. So if biliary atresia with other splenic involvement, like then we can have, but usually not.
So why does it have splenic involvement?
So like other syndromes like BASM, biliary atresia with splenic malformation, then they can have splenomegaly or portal hypertension.
So, but can anyone else answer that without a syndrome, can you have liver and spleen in a extrahepatic biliary atresia without it being a syndrome?
Yes, sir, we can have.
Okay, very good. You are right. Now tell me why. You are saying it's extrahepatic biliary problem. Then why do you get liver and spleen?
Eventually, the intrahepatic part is also involved.
So it is spread of a disease which is primarily biliary tract to involve the
intrahepatic.
Yeah. Now this distension happened in the last 2 months, right? So that fits in with the progress of the disease, right? So you are saying this is extrahepatic biliary atresia. Is that what you are saying? Can it be anything else? Can it be choledochal cyst? Can it be paucity of bile ducts? Can it be a syndrome like intrahepatic biliary paucity? So what are the points for and against? Anyone else also can speak. Everyone should try.
So for syndrome, we'll have to look for other syndromic features.
Okay.
And so she also pointed out history of pruritus in mother in third trimester.
Yeah, so there are a lot of history in the mother which has to be discussed. So pruritus in the mother in third trimester means what? She had also jaundice, bile acid accumulation in the skin.
So this could point out towards like PFIC, progressive familial intrahepatic cholestasis
in mother.
in the child.
So then in that mother is having, does mothers of PFIC babies have this symptom of itching? Is it a hereditary disease?
No, they can have, mothers can have obstetric.
So can you have any other cause for itching in the mother?
Obstetric cholestasis.
Cholestasis is one. So one simple question you would have asked, can the mother have itching without jaundice?
Yes, sir.
No, in cholestasis I am saying.
Oh, sir.
So what did this mother have? This mother had jaundice. So my point is that when you get history of itching in the mother in the third trimester, your immediate question is jaundice with itching or itching without jaundice, and this is itching without jaundice, so it has nothing to do with the cholestasis or bile acid accumulation. So what else can it be? This itching in the mother. Be simply dry skin, which is quite common, and it need not be related to anything else. What else was there in the mother's history?
Burning micturition and with fever in third trimester. There is the history of PRC transfusion.
So this burning micturition and fever for how long?
So during third trimester, she gives history of 1 to 2 months.
Okay. So what do you make out of this? What do you think?
Sir, burning micturition with fever present, that may be UTI.
So UTI for 1 to 2 months. What do you think? So the question is, was the fever for 1 to 2 months?
Burning micturition and history of itching that was present for 1 to 2 months. It was associated fever intermittent.
Again, my point is that in the third trimester of pregnancy, can you get urinary complaints for other reasons? Yeah, so pressure of the gravid uterus, then constipation. So there are multiple other things. So what is burning and frequency? Again, you'll have to make a distinction between all that. So learn to take a details of this history to find out whether it could just be a simple physiological phenomenon in that phase, right? What about blood transfusion? Axel transfusion. So why? Meaning, did you ask what symptoms were there, or why? In what situation did the mother receive this?
She gives history that she was lethargic and paleness was present, but there is no bleeding manifestation, no bleeding per vagina.
So, what do you think is the cause of this paleness?
Anemia.
General,
Maybe
yes.
anemia.
Huh?
It can be anemia.
Yeah, anemia, of course, but what kind of anemia? Hemolytic anemia, bone marrow related, nutritional. So you need fat cells for nutritional anemia.
First and second trimester supplements can be given. Third trimester Ideally, PRC transfusion is preferred.
If there is no time to build up the HP till date, blood transfusion may be a feasible option for that.
So we can give IV iron, no?
It also
It
takes
can be faster.
it also takes time for the HB reaccumulation.
So IV iron is not faster. It is only the delivery which is at a one go, but the hemoglobin say takes the same time, right? Okay. So do you think all these mothers' complaints are related to this baby's condition?
Of course, they are related. That's why she gave the history, past history. No? How can be unrelated? They gave blood transfusion, they pushed HBV, HCV, whatever that got transferred during pregnancy, delivery, and now baby has an early manifestation of that viral infection. That's why you mentioned it, isn't it? I mean, you did not mention father had a fracture once. Okay. So why not?
No, so now argue against what sir is saying, argue scientifically.
No, if it's HBE positive, okay, in a hepatitis B, then the transfer is 90%. And it has happened already.
Too early to say.
So the point is it a hepatocyte disease or a biliary tract? That's the first thing. And you have said it's a biliary tract disease. Then with progress, tension, liver spleen, whatever, general well-being of a child. Okay, if your story would have been first 2 months the child was feeding well, gained weight as well, in spite of jaundice. But thereafter, in the following 2 months, he did not gain weight or he even lost weight. Then I know that there is a hepatocyte element coming up out of a biliary tract. Then the question is, if we are sure this has happened, but if you are not sure, but he has not been feeding well at all, then I still wonder whether you need to consider hepatocyte as well if he has not done well. Could it be that he is doing very well in spite of all this? I said first 2 months well, then deterioration. That's a biliary tract disease causing hepatocyte involvement. Another is not doing well throughout, maybe primary hepatocyte, maybe intrahepatic cholestasis. My third question is, can he be doing very well in spite of all that? Then we will discuss that also. What's your view about could he be doing well? Of course, say loudly, no, never. Why are you so quiet? Okay, you would have all suddenly jumped on me and said, what nonsense. He's going downhill, no? So that is not a question. So I think those details might help us a great deal to pinpoint what's happening exactly.
Anthropometry. Weight is 5.8 kg, which is between -1 to 0 standard deviation. Length is 62 centimeter, which is between -1 to 0 standard deviation. Head circumference is 40 centimeter, which is also between -1 to 0 standard deviation. Weight for length between -2 to -1 standard deviation. Impression is normal. Then general examination. On examination, child is alert, active or febrile. Pulse rate is 120 per minute, regular rhythm, good volume, no radial and radiofemoral delay. Respiratory rate is 40 per minute, and then saturation was maintained. Peripheral pulses well felt, central pulses well felt, extremity warm. Then head to toe examination. Head size and shape is normal. No dysmorphic faces. Anterior fontanelle wide open. Hair normal color and texture. Eyes icterus present. Oral cavity normal. Chest normal. Abdomen distended. Spine normal. Genitalia normal. Then on systemic examination, per abdo on inspection, abdomen is distended. All quadrant moves equally with respiration. Visible veins present over the abdomen. No evidence of any scar or sinuses. Palpation on superficial palpation, soft, non-tender. On deep palpation, liver palpable 4 centimeter below the right corner margin and sharp border firm in consistency. And then liver span is 7 centimeter. Left lobe palpable 2.5 centimeter below the xiphisternum, regular surface. And then spleen is palpable 6 centimeter below the left subcostal margin, firm in consistency. And then on percussion, tympanic note all over the abdomen, and on auscultation, normal bowel sound heard. Rest all system normal. Then impression, 4.5 month old MCH, third by birth order, born of third degree consanguineous marriages, with complaint of yellowish discoloration of eyes since birth, complaint of high colored urine since birth, and history of irritability since 15 days, in completely unimmunized child, developmentally appropriate for age, anthropometrically normal. ANC history suggestive of history of pleuritis in mother and history of PRC transfusion in mother. On examination, palpatory findings suggestive of hepatosplenomegaly with palpable left lobe is a case of neonatal cholestasis. To rule out biliary atresia, choledochal cyst, PFIC.
So now that you know the examination findings, how would you argue for or against the three diagnoses that she has given? So take one by one. Take PFIC. Any arguments for or against?
It is actually cholestasis, which is conjugated bilirubin. PFIC is usually unconjugated.
Can be conjugated. No?
And there is a split 6
It's
and
intrahepatic cholestasis.
cholestasis.
So therefore, it is conjugate.
And there is a spleen of 6 centimeters also.
Yeah. So what does that spleen mean to you?
It may be a
Portal hypertension due to, meaning what is the cause of portal hypertension? Is it pre-hepatic, hepatic, or post-hepatic?
Sir, like he was all right for the initial like 2 months, and then he developed the decompensate. I mean, then he became sick.
All right, in the sense,
Matlab, as per the history given by her, like, matlab, he was less sick. Like if we compare intrahepatic and extrahepatic, he was less sick initially. So to begin with, maybe the pathology was prehepatic, and then it subsequently progressed to involve the intrahepatic biliary radicals also.
means you're talking about portal hypertension.
No, I mean the pathology. So like if we take biliary atresia into account, so like involving the liver and then secondarily causing portal hypertension.
Correct. So when extrahepatic biliary atresia causes portal hypertension, it is always by involving the hepatic
Yes, sir.
parenchyma. So you have parenchymal damage, and that leads to portal hypertension. That leads to splenomegaly, right?
Yes, sir.
So there is no confusion. Question is, can this be PFIC? Is what we are discussing. So your arguments for or against that?
Conjugated hyperbilirubinemia is there, and
For non-sick child.
So non-sick child, only irritability is last 15 days, which also may be because of deposition of bile acids or whatever, itching. So therefore, it's a non-sick child, growth is normal, no failure to thrive. So strongly goes against PFIC, I thought.
so PFIC will categorize into the intrahepatic cholestasis or extrahepatic. Per se, PFIC intrahepatic. Oh.
As the I stands for intrahepatic.
Yeah.
So therefore, it is intrahepatic. How about choledochal cyst?
So the presence of spleen.
Okay. So one is a presence of spleen. What else?
The symptoms.
No.
Any other thoughts?
So there's no history of any cholangitis also. Like,
Why should there be cholangitis? Choledochal cyst is again an extra hepatic
Hepatic.
obstruction.
Hmm.
There need not be cholangitis.
cholangitis.
So our general concept of choledochal cyst is one, it is not so severe, is not so progressive. And in fact, in older children and adults, the description, clinical description is a classic triad of intermittent jaundice. So the word is intermittent. So it is not progressive jaundice. So to that extent, and then as you said, it doesn't lead to subsequent liver damage, etc. So less likely.
What was the birth weight of this child?
3 kg.
So the point I was making is, when you said just now it's between 0 and -1, are you taking in consideration the birth weight? So just make sure of it. But let's believe that this child has a normal growth. Now, if it's a normal growth, then you are talking about the biliary tract disease getting into cirrhosis, then there had to be a deterioration of health. So this is not a biliary cirrhosis. Okay. If your history is right, irritability means itching. Okay. So like a primary biliary, that's fine. But why the liver and spleen? So the question is, this is unlikely a portal hypertension. Now we need to look at what could be the cause of liver and spleen in a child of extrahepatic portal biliary atresia. And there possibly I take the history of the mother. She had some severe anemia. We don't know. Is this child anemic? So my question is, how do you pick up anemia in a severely jaundiced child? Everything is yellow.
So nail beds will look yellow, no? Arm will also look yellow. So other than pallor, other symptoms of
What symptoms at that age? No, you are right. The point I'm making is, if this splenomegaly is not due to portal hypertension, which means not due to cirrhosis, then we must ascribe it to something else. That's number one. Second is, a spleen is too big to be called in a 4-month-old child a portal hypertension. The portal hypertension must have developed after cirrhosis developed. And cirrhosis must have developed by maybe age 2 or 3 months. So this is last 4 weeks, 8 weeks cirrhosis. And already the spleen is so large. So to my mind, search for the cause of hematological problem as well. I'm not trying to connect that biliary tract with this unless we consider some syndrome of which I don't know, which could have such problem. But why not consider it to be anemia? And then my question to you will be, can a mother have some hemolytic anemia that required a transfusion just once in her life? And if that is so, is this the child with the similar thing and also has a biliary atresia? So can a mother for the first time in life manifest hemolytic anemia? Rare, that's why you are doing MD, no? Okay.
so why should HAL trait become so severe to need a transfusion?
So my first question is, what is the mother's health like? Is the mother short? If the mother is short, there could be some issue that she has got some chronic. Unless you say it's constitutional genetic, that's fine. But go one step further and say, could mother be short? If the mother is short, then are you having a chronic? No. So are you having even then some hemolytic anemia? Okay.
Think about what the mother can have and the baby can also have. Which
Hereditary spherocytosis.
Hereditary spherocytosis. Very good.
And then it's autosomal dominant. So you get a diagnosis. Two things are no, but then I realized hemolytic anemia they have jaundice, no?
Indirect jaundice. So this one is direct. So this jaundice is not due to that hereditary spherocytosis.
I think from that point of view, to me, this is unlikely to be already cirrhosis with portal hypertension. This is likely to be two different diseases, one genetically determined, another of an unknown or so-called intrauterine viral infection proceed to biliary atresia. I think that would be the best way to go.
Sir, whether any of the PFIC varieties can be...
See, PFIC varieties are two types. One which is fastly progressive and disturbing the child. Another could be recurrent, but this is neither of the two. And the health is deteriorated by 4 months in PFIC.
because liver and spleen both are affected, could this be a storage disorder? Because you have liver and spleen, both are large. We think it's larger than what it should be if one was the primary cause and the other was the secondary cause. Now you have both which are large. So are you thinking of a storage? And obviously the reflex question, now there's all the labs will write reflex test. Means I've got business, I want more business. So reflex question is which storage disorder?
So like in case of storage, other history, though the child is small, like convulsion, developmental delay, history of hypoglycemia. And so like if at all we consider Niemann-Pick and Gaucher can
But I agree with you, most of them don't present as a deep jaundice continuing for 4 months.
What is the feel of the liver? Form. That means the liver is definitely abnormal. Exactly how much is the spleen? Sometimes you may
She
say
said
it's not
6 centimeters.
little too big. Can it still be a hepatocellular disease giving rise to portal hypertension? So little uncommon, the spleen is too big. But last 15-20 days, the disease is going progressively, at least the clinical manifestations are now apparent, and therefore the progress is there. Is there any such rule that the spleen should be coming up only later or earlier, or can this
So
be
that's
made?
not the point. The point is that health is good, weight is good, and there is no ascites also. Means these are the two things which go against liver disease causing portal hypertension.
Not going by spleen size. That's not important, but this is not a progressive hepatocyte disease by normal growth. And therefore, by now, biliary cirrhosis would have been presented with deterioration in weight, thereafter a liver which is firm, and maybe spleen has started coming up. That's all. But this does not fit in that. That's the only reason I brought in. And the mother's anemia. Which mother gets UTI or something and a blood transfusion? Okay, which means she must be anemic already. Okay, all thalassemia minors are picked up in pregnancy only. So if she has an anemia, then I think that, but she should be short as well. Then I think we get a diagnosis, and then you can look at her eyes also, or at least some bilirubin, and that could be indirect bilirubin, maybe 1.2, 1.8, something of that.
They have my dictors G6PD. Not have gone noticed.
Investigation CBC-HB is 9.3, SCT 26.9, counts are 11.2 and platelet 178. RFTSC BUN is 4 and serum creatinine 0.3. Total bill is 20.3 and direct bilirubin 10.5. OTPT 372 and 197. ALP is 537. Total protein is 6.4 and serum albumin is 4.1. PTINR is 19.8 and INR is 1.65. GGT 201 unit per liter, AFP is 1672 Ng per ml. Then free T3 is 4.04 Pg per ml. Free T4 is 2.09 Ng per dl, and TSH is 0.34. And USG A plus P, liver, caudate and left lobe enlarged with IHBR dilatation, mild periportal echogenicity, small portal nodes noted, chronic active liver parenchymal pathology needs to be ruled out, and gallbladder contracted with raised echogenicity.
Said something about the portal hypertension. They have written some
Small portal nodes noted.
earlier than that. Once
Mild periportal echogenicity on USG.
You said gallbladder is visualized,
Contracted with raised echogenicity.
rarely some case was reported that the child had a lymph node which was pressing upon the extra hepatic outlet and it mimicked the extra hepatic portal hypertension. That is just once in a way. But otherwise, lymph node pressing and giving rise to this should not be our first consideration.
What is your interpretation of the investigations? What about the hepatocyte function or dysfunction? What do you think? What do you think? Is hepatocyte function affected?
So the synthetic functions of the liver are affected because she told the PTA was 19.8 and INR was 1.65. So there is, the synthetic function taking into account PTINR is affected, but albumin is normal.
Can there be some other explanation?
Fat soluble vitamin deficiency could cause deranged PTINR.
So if there's a fat soluble vitamin deficiency, then you may have the same PTINR. So what are the other liver function? What do you think of the proteins? What do you think
Proteins
of the enzymes?
Proteins are normal.
Okay.
Total protein and albumin both. And the enzymes are elevated. There is transaminitis. More than 3 times they are increased. And there is cholestasis, direct hyperbilirubinemia. And so ALP is also high. So this points out to us that there is some sort of biliary obstruction. And GGT is also high, so which again further confirms the biliary obstruction.
Fine.
I think when you interpret liver function test, bilirubin tells you the extent of the liver disease. Okay. Enzymes tell you the acuity, like an acute viral A, thousands. Albumin tells you chronicity, and the prothrombin tells you complication or seriousness. We want to know 4 things. Now you have a biliary tract here. Hepatocytes are already involved, but bilirubin is not so high. Enzymes are coming up slowly, and therefore this is a chronic hepatocyte involvement. It's neither acute nor severe, possibly not serious at this point of time. So there's no doubt that hepatocytes are involved. The question is it enough to explain it as portal hypertension? That was the discussion we had. Okay. But otherwise, what he said, interpretations are perfect, right?
And to add, increased prothrombin time not returning to normal after vitamin K, because the synthetic function depends upon that. Otherwise, an obstructive jaundice with vitamin K and everything comes to normal.
Any comments on the gallbladder? So normally in extrahepatic biliary atresia, do you expect the gallbladder to be seen? Absent gallbladder. So here you are able to see it. So thoughts on that?
have to look at the gallbladder contractility, like pre-feeding and like after feeding, what was the gallbladder contractility, whether there was a reduction by 60% in the gallbladder contractility post-feed. This could point out towards one. And other parameters like how was the portal vein, like any dilatation or any triangular cord sign. Like this all can help us in isolating like for biliary atresia.
I was just thinking that because the gallbladder is there, whether it's not the complete biliary atresia, but a variant form like paucity and something like that, but not the complete atresia form. So that is something to be thought about. How will you manage this baby? Baby is there, no? Call.
Cholestatic supplements. Fat. ADEK. Vitamin B complex.
What investigations will you do?
Sir, additional to this, liver biopsy can be considered.
Additional to what?
LFTs, USG.
So will you do a HIDA scan?
It doesn't confirms the biliary atresia, but rules out.
So rules
It
out.
doesn't.
Rules out. No, we'll rule it out by HIDA scan.
MR cholangiography can also be done.
Yeah, but what about HIDA scan?
It's not confirmative.
So it's not confirmatory, but I want a bigger reason why you will not do it.
So like could be a waste of the precious time frame which we have.
Absolutely. So age of the baby is extremely important. So anyway, it has its problems about specificity. But in a baby who is 4.5 months old, out of question. You wouldn't waste time on that at all.
So I had one more doubt. So sir, like suppose in a remote hospital and like a patient has come to me, I have done the like ultrasound. Within 3 months span, he has come to me. So and I'm suspecting biliary atresia. So I can refer the child to a tertiary hospital, like in view of liver.
Yeah. So ideally, you should refer as early as possible to a tertiary care center, which can take care of everything to save time. That is the most important.
Today's philosophy is more aggressiveness. And don't waste time doing any of this. Explore this therapy. On the table, surgeon decides whether he wants to go further or otherwise. Because it has not been very definitely diagnosable condition between neonatal hepatitis and biliary atresia. And the reason is both are of the same disease but a different spectrum. One fellow goes into hepatitis, another comes with biliary problem, and therefore etiologically both are probably both are due to same. The difference is not easy by HIDA scan, by phenobarbital stimulation, by histopathology. No, you say mostly this, but maybe this. Therefore, if you want to save the liver from getting worse, explorative cholangiography and a decision right then whether you have a hepatitis and you come out or whether you want to go further by that. Of course, finally, even Kasai will end up with a liver only, but at least we will save the liver from getting worse.
You have any definitive investigations after that besides the liver profile and all? So what has been planned now?
Sir, biopsy, liver biopsy.
So liver biopsy you will be able to do with a prothrombin time of 19.
No, sir. After stabilization.
How will you stabilize?
Vitamin K.
Very good. So you will give injection vitamin K and then see whether the prothrombin time is improving, and then okay. Any other questions, anybody?
About last time's final diagnosis. Don't keep secrets.
Yeah.
A 9-year-old. Vishamat. Yes, sir. IgG.
Sir, the big girl with a liver which was left lobe was very firm, right lobe was almost not felt, and a huge spleen. She had come with abdominal distension as the chief complaint.
Since last 3 years.
Yeah. So what was it?
Also, sir, history has a different perspective according to mother. Actually, mother was not there. Mother is in the duty, so I called her, and she said it has been started at the age of 2 years. The abdominal distension. Yes, at the age of 2 years, she had the abdominal distension. After that, she has received some medication for 6 months. Some local medication, native medications. After that, again happened at age of 7 years, and then 10 years, she was referred here. So we sent her out.
But is there history of jaundice?
No, sir. The mother is not telling about the history of jaundice. She hasn't given any.
So you are saying your final diagnosis is autoimmune hepatitis.
Autoimmune. IgG is came out to be very high. Anti-LCM is negative, and anti-SM is positive. Smooth muscle antibody is positive, but Wilson workup is negative. So autoimmune. Sorry.
ANA.
Sir, 2+. Not calling.
And what about the second child was last time? The one with repeated pneumonia, 3 pneumonias and good health. 4-5-month-old baby. Here we had discussed whether it was aspiration. It was in the ICU for 10 days in one of the admissions.
We have planned a PID workup.
But how is the baby now?
He's fine. Planned discharge
And discharge.
after 1 to 2 days of antibiotic.
Any other investigations or any structural anomaly has not been confirmed.
So CT scan was done for him, and it is suggestive of consolidations only. Nothing else.
Okay, fine.
Multiple pneumonias.
Yeah, that was a 5-month-old baby who had come with 2 past pneumonias and 1 now, like fever and breathlessness, second day breathlessness. We had discussed whether it could be aspiration and all that we had discussed, but we said it doesn't fit into aspiration. And the best part is the baby's growth was good. It was exclusively breastfed and baby's growth was good. This one they are saying they are sent a primary immunodeficiency workup. So far nothing has been proved. And the big girl was autoimmune hepatitis.
Same site pneumonias, different type pneumonias. Different site pneumonias.
I think wide spectrum of diseases we known, but nowadays these serious diseases are growing well. India is improving.
Online friends, any comments, any questions?
None. Rajesh, today's view was very good. We could see all the slides and we could see all the speakers as well. Thank you very much. And
Good,
whether
good.
bronchoscopy
Chalo,
was
thank you.
planned for, yeah. Thank
Sorry,
you.
bronchoscopy?
Was planned for the 4-month-old child of last time.
No, they are saying that because they got a CT normal, they thought normal as in not suggestive of anything. They have not followed that up, that
Okay.
angle up.
Okay.
Okay.
I think
Fine.
CT also does a virtual bronchoscopy.
Yeah.
Yeah. Okay. That's it. Thank you. Thank you
Okay.
very much, Dr. Amdekar sir and all faculty. Thank you, Rajesh. Thank you all the
Thank you. Thank you everyone for joining in. Thank you. Please keep telling your student friends to log in next Thursday. Thank you.
thank you,
Thank
Rajesh.
you, everyone.